record button. And then welcome on our panel member, Dr. Drew Falconer with the Inova Parkinson's and Movement Disorders Center. Dr. Falconer, welcome. And before we go through who you are, I want to say a big thank you personally from me and my family members. About a year ago, we had Dr. Falconer on talking about Parkinson's and movement disorders in older adults. And I was just basically, I was the moderator, but I was in the audience listening like everyone. And he began to sort of talk about how tremors are something that you probably don't have to live with. And it dawned on me that both my mom and my cousin have significant noticeable tremors. And I introduced both of them to Dr. Falconer, and I might tear up because I have to say that after meeting with you, it's been life-changing. Both of them, their tremors through their treatment with you have been eliminated and minimized greatly. But a great example of just how significant this was is that my cousin said to me, he said, this is the best thing that's ever happened. I drove into work today and I didn't spill my soda on my pants, and I can actually make a phone call without bracing my hand. And I mean, when I heard that it's life-changing, my mom is in her 70s, and the side benefit that she has seen most significant is how much energy she has, because I imagine the amount of energy she was exerting, either trying to hold back her tremor or actually, the shaking was significant. So thank you so much, Dr. Falconer, you and your team. And before we dive into the topic, for those that don't know who you are, can you give us a little bit about your background and what your center does?
Absolutely. And thanks for having me today, Steve. It's always fun to join you in the community that's coming together to learn more about these conditions. And I love your family. They're amazing. And they are a perfect, thank you for giving that example. They're a perfect example of what I hope we can talk about today. And that is the power of approaching these conditions with the idea that we don't have to accept less than best. We really don't have to accept tremor as something that just has to be part of it. And we'll hopefully go through today with essential tremor why most people with essential tremor don't seek treatment and how we can bridge that gap. Because at the end of the day, every day I see people with Parkinson's with tremor, and I have yet to see somebody where there isn't an obvious next step that they haven't taken yet. We usually take that together, that step, and things get better. That's the beauty of treating these conditions in 2021 versus 1985, though a lot of folks are still stuck back in the 80s with their leg warmers, their scrunchies, and treatments from about that era. But a little introduction to myself. My name is Drew Falconer. I am a neurologist by training, and I joke a Parkinson's and movement specialist by extra training. I direct the Parkinson's and Movement Disorders Center here at Inova in Northern Virginia. We're a pretty sizable center now. Even from last year when we met last, we've gained yet another movement disorder specialist. So we have 4 docs that all we do every day, 5 days a week, is see patients with Parkinson's, with dystonia, with essential tremor in a very high level specialty type environment. And we do that not only through telehealth, which we might talk about today, but telehealth is wonderful. It just increases access to specialty care like ours. But we have clinics based out of Alexandria, Fairfax, Fair Oaks, and Gainesville, Virginia, because our whole role, the whole idea behind our center is that we want to emulate and bring academic center level specialty care into the community. And our mission every day is access. If you don't have access to one of us, either nearby in one of our many locations or virtually, then we're not really building that relationship to get you better for the long run, right? And so we've built this center with the idea that patient care and accessibility is number one on the list before everything else. But a big second best, and Sonia's gonna hate to hear that, but I think she gets it, is our educational program. We've dedicated ourselves to education. We run all kinds of educational programs that are free to everybody on everything from essential tremor, Parkinson's, other ways to manage things. And we also offer for the community all kinds of wonderful free classes from an exercise perspective, speech perspective on down. So to summarize that, we are a center that is built like a community, and we are here to walk the walk with you and your loved ones as they go through whatever they're going to go through, and be there at every step to intervene and to give access to things that help. So it's my quick plug. If you want to learn more or follow our center, please, please, please email our outreach and community director, Sonia Gao, who is amazing. She is literally there for everyone at any point for anything. She'll even tell you a good place to get a cheeseburger nearby. She's incredible.
And she just dropped her contact info into chat for everybody. And man, not surprising, Dr. Falconer, that you can see the floodgates of questions have opened. I'm going to let you drive this bus. Sure. In terms of if you wanted to sort of share some resources, or if you want to just dive in and start tackling these questions. Now, you're probably one of the most tech savvy attendees that we have on our discussions. So if you want to pick and choose the questions and address them, I'll let you handle that. I know we do have some folks that are listening on their phone. So if you want to address them, just make sure to restate that questions.
We can do it. Let's start by just talking about essential tremor. Is that fair? Because we're here to talk about this thing called essential tremor. And remember, essential tremor is very different from Parkinson's disease. It really is a different condition that is as different as white and wheat bread. And I think by just tackling in the next few minutes the basics of essential tremor, of what we do to treat it, and of why people don't treat it, I think that'll take care of a lot of the questions, and then we can filter from there with things that maybe we didn't address.
Okay? Sounds good.
So I want everyone to realize that yes, essential tremor is very different than Parkinson's. I can't tell you how many folks who go to a general neurologist or somebody, well-meaning doctor, who are told that they have essential tremor, and years later, it's either Parkinson's or something else. And they're usually met with this idea that, oh, it's all just kind of part of the same kettle of fish. Well, it's not. They're very, very different. So Parkinson's disease as a condition is, and I say this 1,000 times, but it's true, is nothing more than a deficiency of the hormone dopamine in the brain. You're not making dopamine, the dopamine tank is low, and you get the symptoms that go along with Parkinson's. Essential tremor, you're making all the dopamine you need. This is not a dopamine chemical problem. Essential tremor is a condition that is not from a chemical issue. It's actually a genetic trait that people have carried with them that becomes symptomatic at some point in life. And it actually comes from the very back part of the brain, a part of the brain called the cerebellum. If everybody remembers your picture of the brain, it's this big lobulated thing. And then there's like, you know, the old St. Bernards that would carry the thing of rum underneath their chin for the mountains. Well, I always think the cerebellum's in the back, and it kind of looks like that cask that the St. Bernards carry, this little lobular thing in the back. Well, your cerebellum is the part of the brain that coordinates movement. It's the part that when you go to reach for something is targeting in your muscles to be able to grab it. It's the thing when you go for a walk that's keeping your cadence in a very smooth and organized way. It's when you're eating, it allows you to stab the peas because it is the targeting center that's allowing for smooth movement. With essential tremor, the cerebellum didn't develop properly and is a little bit off. And that little bit of off leads to a difficulty with targeting movement. And that's why with essential tremor, we think about it as a cerebellar problem because it affects how you move through space, right? This is the tremor that's not at rest. It's not the patient who's sitting there watching TV and the hand shaking. It's when you're reaching to grab something, you shake. If you're trying to write, there's tremor. If you're going to drink out of a cup, for a lot of folks, heaven forbid, they hold it with one hand, it'll spill everywhere. And it tends to be made worse, of course, by movement. And so if you think about it as a cerebellar problem, as a problem with that portion of the brain, then the way we treat it starts to make sense. And also how it runs in families starts to make sense. So yes, this tends to be a genetic condition. In fact, the old term for essential tremor was benign familial tremor. But we stopped calling it that because if you have essential tremor, calling it benign is kind of insulting. It's definitely not benign. And it doesn't have to run in families. So the familial part isn't always true. It tends to be about 2/3 of the time, though, you can track it where it tends to run in families. And so we changed the name to be essential tremor because it tends to affect the essential activities of daily living, eating, drinking, using your hands. So yes, somebody even asked this, is it genetic? It is. It tends to run in families. It doesn't always have to. And it tends to have this weird penetrance where people get it at different ages. So if you have someone with essential tremor, they tend to say, oh, grandma had it. I remember her in her 80s, her head would shake and her hands would shake. And my second cousin Arlene got it at 35 and everybody always noticed. And my third, my sister my half sister had, this was the lady yesterday, half sister had the tremor that came out when she was 40. So it tends to be there, but not necessarily what we call dominant, where every person tends to get it. And people tend to get it in varying severity, varying presentations. But as with all things in life, it does tend to get a little worse as time goes on. I mean, that's what life does to all of us. But the thing is, people tend to not treat essential tremor. There's this, and I'd be interested in folks who are on the call who have essential tremor and see it in families, because this doesn't always hold true. But usually it takes a lot to get an essential tremor patient to come see me, a movement specialist. In fact, if you look at the landscape of neurology across the US, we have about 1 million people with Parkinson's disease. There's 6 to 8 million people with essential tremor. So we're talking 6 times the volume of people with essential tremor than Parkinson's. And yet in my world, being a specialist who treats tremor, I see 80% Parkinson's and only about 10% essential tremor. The problem is, this is a condition that runs in families, right? And so people tend to fall trap for the experience of their relatives. And I mean that in a very respectful way to your grandmother and your cousin, whoever had tremor. Don't think I'm telling you not. But it's this idea that it's a tremor that starts earlier in life. So people learn to acclimatize to it. They learn to deal with it. They make accommodations subconsciously and consciously to deal with it. And they have generations of people who've said nothing helps. So, if I had a condition and my dad had it, and he always told me, oh, I took a medicine back in the 70s, it didn't do anything, I would also come up with that. I would also be ingrained with that idea that there's nothing I can do about it. And so what we find is that the vast majority of essential tremor patients don't seek treatment for it. They don't try treatment, or they tried one thing 20 years ago, it didn't work, and they just gave up on it, right? But that's not the case. And that's where education is so key. That's where things like this are so key. And that's why outreach to folks with essential tremor are so key. And by the way, it's really hard to find people with essential tremor to talk to, even though we have 6 to 8 million people in the US with essential tremor. I'll give you an example. We give a talk on Parkinson's, let's say, for our center. We go through the modern medications, treatment algorithms on down. We get 250 to 600 people showing up, right? We give a talk on essential tremor, and we're lucky to pull 20 people. So it is just a community that seems very comfortable resting on their laurels because they think there's nothing better. And that's not good, because we can treat it. Because the honest truth is, we have 4 things that work well for essential tremor. And we have, I think there's 5 medications that are currently going through phase 3 trials that are going to be available to us in the next year or 2. Now, let's run through those 4 things that treat essential tremor. And I am not going to say alcohol, even though alcohol does potently suppress tremor and essential tremor. only because that is not a treatment. That ends up being a problem, right? We don't want you self-medicating for this. We want to actually treat it. How are we doing so far, Steve? Getting boring at all?
Oh no, this is great, and you're speaking right to the heart of my family. But we got tons of questions, but I can see you're answering a lot of them as you're speaking. And then, like you said, we'll keep them coming, folks, and we'll dive in and fill in any of the blanks. So great job.
Fantastic. Okay, so for the treatment, I am going to let me see. I am going to borrow the whiteboard here. And I'm going to call them out so that people will see them as we go. But in the world of essential tremor, yes, it does respond to alcohol. One of the classic traits of essential tremor is that you drink a cocktail, you have a glass of wine, and it calms down. But again, we don't want you self-medicating to treat, because we're going to then create our own dependency problems with alcohol. We have, in the world of essential tremor, 3 good medicines that work for essential tremor. They tend to, we list them and we approach them in the order of diminishing response, which I'll talk about in a minute. But the thing people tend to miss is that usually, and there's good data to support this, that using the different medicines in combination tend to be more effective if using just one of them doesn't work well. And I see people all the time who say they tried Propanol 20 years ago and never did anything. They tried maybe Primadone later on, it didn't do anything, but they never tried them together. The reason why they work well together is that these 3 different medicines approach making the tremor of essential tremor better very differently. And so if they're making the tremor better differently, then there's no reason we can't use them together to get what we call a synergistic effect. So the most common medicine, the one we go to fresh out the gate for most people, is a medicine called Propanol. So there are 2 versions of Propanol. There is an immediate release version that you can take up to 3 times a day that works for about 3 to 4 hours. And then there's a once daily extended release that we take once a day in the morning that lasts all day and all night. So I'm going to call them Propanol IR for immediate release and ER for extended release. Now, for most people, we start with Propanol ER, the idea being that we're going to try to suppress the tremor all the time. For some people, no matter what the combo they're on, we can also give you a little low dose of the immediate release that you can take kind of when you need it. So let's say you're going out to a party and you don't want to shake, you're going to a business meeting, you're going to shake. You can take a little bit of the immediate release before you go to that tremor-inducing event, or where you want it to be extra suppressed, as kind of a fix-a-flat or fill the gap when you need it. Now, Propanol is an interesting med. It was never really indicated for essential tremor. It was originally a blood pressure medicine, and it's in a category of medicines called beta blockers. There's a lot of folks on the call are probably on its cousins, metoprolol, which is Toprol, and there's some other ones that really just work on the heart. Now, Propanol is a beta blocker just like metoprolol. It works on blood pressure and heart rate and AFib just like metoprolol or Toprol does. The difference is Propanol is not specific just for the heart. And if the beta blockers, by blocking the beta receptors, slow down the rhythmic contraction of the heart to calm blood pressure and heart rhythm problems, well, Propanol, by working everywhere, calms down the rhythm of the heart and calms down the rhythm of tremor. And so Propanol works because when it blocks the beta receptors in muscles, that blockade calms down rhythmic tremor. And we tend to get very good response with Propanol. Usually with Propanol, we tend to see a response in about 80% of people. And for most people, especially once they start treatment, Propanol can make the tremor stop. It's a very good medicine to try. There are some potential side effects. It does lower heart rate. That's it working on the cardiac function. So if your heart rate's already at 50, it might make you a little tired and lightheaded. If your heart rate is in the 70s or 80s, most people tolerate it without issue. So we tend to start with Propanol only because the risk of a side effect is very low. It's easy. A lot of people have high blood pressure. You get the 2 birds with 1 stone of getting blood pressure control, and it really does tend to help. Now remember, tremor is tremor. Tremor is a symptom. We can all get tremor, right? If I drink 3 cups of coffee, I might have some tremor. If my kids wake me up all night and I'm stressed the next day, I might have some tremor. Tremor happens. with essential tremor, you got to think about it, that threshold for tremor tends to be lower. So for all those things that trigger tremor in everybody, low blood sugar, missing a meal, being stressed, being angry, a whole lot of caffeine, those things will make tremor worse with you as well, but it usually makes tremor even more pronounced. So I have a lot of folks that say they drink a cup of coffee and their tremor is just out of control. That's because of the stimulating effects of the caffeine. But on that idea, if the threshold for your tremor is lower, you have to remember that treating tremor with essential tremor is all about that threshold. We need to have the medicine on board and find the dose that is at the right dose to hit the threshold to suppress it. So for some people, you start at propranolol ER 60 milligrams a day. They get 10, 20% better. So what do? We bump it up. They get 50% better. You bump it up, they get 70% better. It's about finding that dose you need without, of course, giving side effects. Now, to that point, I don't want anyone to try the lowest dose and say, oh, it didn't work, I'm just going to stop it. It probably just wasn't enough. And that was the point of what I was trying to get across. Okay, so the second medicine we have for essential tremor is Primadone. The old trade name was Myceline. So Primadone has been around since the long time, 70s, 80s, was originally an anti-seizure medicine because of what it does to suppress activity in the brain. So propranolol works outside of the brain to make tremor better. Primadone works in the brain to try to make tremor better. And how it works is that Primadone breaks down into an agent that suppresses the cerebellum. Remember, we said that essential tremor is a cerebellar problem. The cerebellum is misfiring to give that tremor with activity. Well, Primadone suppresses that inappropriate firing that's coming from the cerebellum. Now, it's a medicine that does make people sleepy, and so we tend to use that as a second line agent only because we tend to get about 60% response with it, but about a third of the time people can't tolerate it because it makes them sleepy. Now, the third line medicine is a medicine called Topiramate. The trade name was Topamax, which was originally a seizure medicine, then adopted for headache control. It's great for headaches. And then we realized, oh my goodness, about a third of the time, tremor gets better with essential tremor. So as Topiramate's one we tend to add on to these other two or add later on if nothing else is working, because it's that diminishing return. We have a lower chance of it working. And Topiramate has some weird side effects. It can make you a little foggy headed. It can give you kidney stones, which are never fun. It can make your fingertips tingle. So that's why our order tends to be propranolol, especially the long-acting one, where we tend to see response about 80% of the time. Then Primadone, response 60% of the time, Topiramate 30%. But adding them in combination, because they all work differently, tends to have a synergistic effect and works. Now, there's still some folks that even after these three still have pretty pronounced tremor, or they have tremor that just irritates them. If that's the case, we do a whole lot of deep brain stimulation to target essential tremor. It is a grossly undersupplied group of patients, given the profound effect that DBS has on tremor. DBS, we remember in our world of DBS, of deep brain stimulation, it was originally approved in 1996 to treat essential tremor. So DBS was an essential tremor tool before it was a Parkinson's tool. And it works, guys. For 50 to 60% of folks, if you do a DBS with essential tremor, the tremor stops completely. It stops completely with no medication. And that improvement is something we can sustain for life. For the people that it doesn't stop completely, we can see 80 or 90% improvement with just some breakthrough tremor at times. And that breakthrough tremor, usually we can then treat with medication. So essential tremor is life-changing in the world of DBS. It is a beautiful thing to do and witness, because you will literally go from shaking while writing or moving to stopped. And it's something that's programmable. It's something that's adjustable. It's something that as time goes on, we change how the device is blocking the signal causing tremor, and it keeps you better. And so I want folks to remember that if you tried the medicine, it's not cutting it, we can still make the tremor stop. And our job is to really take that tremor that's bothering you and do everything we can to get it to go away. Okay, that was kind of my 2 cents on essential tremor. I think that summarizes what we do every day here in clinic. Let's see here, Steve. Let's see what other questions we have. Okay, so, oh, we've got a whole lot. You weren't kidding. Okay,
Yeah.
so someone said, wow, I got to scroll up to the top. Okay, so someone mentioned cutting edge research. There's a number of different things. So one, there is a tool called focused ultrasound that can be done for essential tremor. It uses ultrasound, so sound waves, to create a lesion in the brain. So we know the pathway that essential tremor runs on. We know where that tremor is going through the brain. With DBS, we put a lead into that pathway that we can put energy through to block it and makes the symptoms better. And we can adjust that energy as time goes on. Focused ultrasound doesn't use a lead, it uses sound waves to burn a hole in that pathway to block it. The reason why we really don't do it all that much for essential tremor is because once you create injury to the brain, you're then putting a structural problem on top of an electrical one. And it really limits what we can do later on because it's not adaptable, right? But there's a lot of new stuff coming out. There are a lot of new medications. There are a lot of wearable devices. So again, talk to a movement doc about essential tremor. We'll talk your ear off on things to treat. Yeah, see, look, Steve, you're right. We answered a lot of these. Talked about Primadone, Propanol, and other medications. There are really only 3 medicines we use. Someone else mentioned gabapentin. I've been doing this 6 years and have put probably hundreds of patients with essential tremor on medicine. I've tried gabapentin for years, have seen one person that has made the tremor better. If you look at the data on gabapentin, it tends to be an anecdotal response, not something statistically significant. So we don't really consider gabapentin one of our medicines for tremor, just because for the vast majority of people, it doesn't work. Someone said, is there a correlation between essential tremor and other conditions? Yes and no. So there is a correlation between essential tremor and walking problems. That's one that people tend to miss. So if your cerebellum's a little off, your walking can get a little off too. And if you get a little unsteadiness in your walking or wobbliness of your gait, that tends to be part of essential tremor. We used to call it essential tremor plus when you would have tremor and walking problems. And then we realized that everybody had it. And so by calling it something different was nonsense. So we just call it essential tremor now. Is there a connection between essential tremor and Parkinson's? Technically, yes. If you have essential tremor, you have a slightly higher risk of developing Parkinson's, but it's not a really significant difference. We do have some people that have both essential tremor and Parkinson's, but it's extremely rare. So I think for the general person, there really isn't all that much of a connection. Just because you have essential tremor doesn't mean you're going to get something else. And someone asked, is it a seizure disorder? No, it's not a seizure disorder. By definition, a seizure disorder is the brain misfiring in a synchronous electrical activity to give a symptom. This is more that the regulatory system is firing off, which makes it very different. Let's see. Wow. Oh, can a Maryland resident with Medicare be treated by you? Sure. We have folks from all over the place that will drive in for an in-person visit. So come on to us and we can definitely help.
And your practice accepts Medicare?
Oh yeah, we absolutely do. In fact, being a community system like Inova, the vast majority, we accept almost every insurance. And in our world of essential tremor and Parkinson's, I mean, I think my clinic is 80% Medicare. So we like Medicare. We've learned to work with it well. Someone said my practice just performed DBS round 2 on my dearest of friends. God bless you. I'm going to take it that it has worked already, which is a wonderful thing. Yeah, DBS is life-changing for essential tremor and Parkinson's. I mean, it works. It's a beautiful, beautiful thing. Does it affect the ability to dance in an organized way?
I like that.
So if you're born like me with the inability to dance in an organized way, is that the same or different? No, it can. It can affect coordination, which can affect the ability to dance. But guess what? Movement-related issues, walking issues, dancing, those are things we can actually rehab our way around. So if that's what's bothering you, then we need to get you in with a good physical and occupational therapist to train the body to move better. And we'll get you dancing again. It happens all the time. Let's see here. Oh, good. People got the whiteboard. I'm just catching up on people.
Yep. I think the next one is, how do you do deep brain stimulation?
How do you do deep brain stimulation? Okay, so deep brain stimulation is a two-part surgery. So it is a brain surgery, and it is a big thing for long-term gain, right? It's a big step, and then we have a tool in place that we can interact with and adjust forever to make things better. So what happens with DBS for the first surgery, you go in and the whole purpose of the first one is to put leads into the brain that go to the pathway that the tremor runs on. We can get to this nucleus called the VIM nucleus in the thalamus for all the science nerds out there. That's where the cerebellum actually runs through to get to the rest of the brain. And so the first surgery involves a lot of mapping and prep on our end. And then you go into the surgery, and Dr. Shania at our center, our neurosurgeon who does our DBS, puts the leads through using this really high-tech frame into those targets. And what's really cool about it, and actually you're going to think this sounds crazy, but patients really like it, is that you're awake for part of the surgery. And the reason why you're awake is that we want to see you shake and get you to do things that are shaking. And then we turn on the lead and it stops. It's the coolest thing you've ever seen. It's almost a religious moment when, for the first time in 40 years, someone stops shaking and people cry. It's a wonderful, beautiful thing. But it's also important because we want to make sure that we're in the right spot, right? And so we turn it on, the symptoms stop, we don't have side effects. They turn it off, Dr. Shania puts everything, closes everything up. And then you have a second surgery, usually 2 weeks later, and you're asleep for that one for the whole time. And the whole point of the second one is to put the generator, the thing that runs the therapy, under the collarbone and hook up the wire between the generator and the leads. And everything's on the inside. It's if you run across somebody with DBS, you probably don't even know it because everything's inside. But it's built on a pacemaker-like device that lives under the collarbone. And then there's a wire that we bury all the way up to go to where the leads go in. And the cool part is I interact with it and adjust and program it via Bluetooth. So it's a secure connection, and you just adjust it, and then the symptoms just stop. And the cool part too is you get your own programmer, or with Abbott, you get to put it on your own phone, and you can adjust it. So let's say you're going out and you're going to do something that's a little stressful that might bring out tremor. You can bump it up, and the tremor stays more suppressed. You can interact with it. Super cool. The other cool thing is that with the Abbott system, we can now do remote programming. So I can actually connect to your device remotely, wherever you are, if you have cell coverage, if you have internet, and we can do a virtual visit through like secure FaceTime and adjust your device and get that tremor to calm down without having you to come in. It's awesome.
Another question from Betty: are treatments associated with cognitive decline? Has there been any results that these medications or DBS?
Yeah, it's a good question. No, they don't really cause cognitive decline. So the medications definitely don't do. DBS, if you already have established dementia, that's one of the contraindications for DBS. If you have dementia, we don't want to go poke in the brain because it runs a risk of making it worse. But if you are cognitively intact, if you have mild cognitive issues that come with age, none of this stuff is going to make it worse. That's the nice part.
Great. Somebody brought up focused ultrasound autonomy.
Yeah, it's thalamotomy, actually.
Thalamotomy.
Yeah, that's what I was mentioning before. Before DBS and with focused ultrasound, it's this whole what is old is new again. It's like how bell bottoms are coming back, apparently, my wife told me. Before DBS, we used to, in really bad essential tremor, put a lead into the brain to go to this pathway. And at the tip of the little probe it would heat up and it would burn it and create a lesion. So we used to use lesions to block tremor, and it works. It works for a period of time. And then your brain kind of works around the burn spot and the symptoms come back and they can go back in and burn more holes. Well, back in the 50s and 60s, we realized that as that lead was heating up to create injury, the symptoms stopped at a lot lower power than we needed to burn it. And thus the world of DBS was born, the idea that it's an electrical pathway and we can actually block it by putting controlled energy into it. Well, focused ultrasound is just a different way to do a lesioning procedure, just without putting a probe into the brain. And again, they put you, it's in an MRI scanner, they put you in this big helmet with about 1,000 ultrasound transducers that all send sound waves to a target, that those sound waves coalesce and create heat. And it creates injury. It's just a different way to block the pathway. It's pretty tough. Right now, you can really only do one side, because if you create injury on both sides and you miss, it's permanent. If the injury is in the wrong spot, it's permanent. It's also not adaptable or programmable. So you might feel better for a few years, and when it comes back, we're a little sunk because do we burn another hole? We can't do DBS. It's just there's a lot of reasons why we haven't ordered a single focused ultrasound in the past 3 years that it's been available.
A couple of questions related to who can diagnose this, and obviously you can, but then also there was a question related to insurance. Will insurance cover this if you just have a tremor when you're under stress or emotional issues?
Remember, tremor happens. Tremor is a symptom of anything. You really need to see a neurologist or a movement specialist for that diagnosis. The big thing we want to differentiate between is Parkinson's disease and essential tremor. That's the big differentiating point, because if that's a gray area, we got to clear that up. Outside of that, you can have essential tremor that's made worse by emotion. You can get functional tremor that comes out with emotional states. They're all just variations of the same pot of its tremor. We still need to treat it.
What's the risks of DBS? Like
Yeah. So it is surgery. It's a device. So there is the risk of the surgery itself, though in our world of brain surgeries, it's very, very low and would not be considered even a moderate risk procedure. I mean, we're putting a lead in the brain, so there's always the risk of bleeding, of other sort of issues from that. Knock on wood, hasn't befelled us yet, and we're doing fine. Technically, it's a device in your body, so there's always the risk of infection, but again, extremely rare. But you'd have a good conversation with me about that first, and about with the surgeon, definitely, who will, I'm sure, tell you all of how well they do it and all the low risk that they impart. So in our world, it's not a small thing, but it's something that tends to be very low risk.
Claire has a good question. She says, I have an action tremor in my dominant hand, which has been diagnosed as focal dystonia. What's the difference between this and an essential tremor?
Well, great question. The difference is in what's causing the tremor. So in dystonia, all dystonia is an abnormal or inappropriate tightening of a muscle. So if you're having dystonia in the arm that's pulling the muscle too tight, the hand can shake as it's trying to fight against the dystonia. It's something that is very different than essential tremor and is treated very differently too.
Okay. Joe wonders if someone has a significant tremors following a stroke, will the same treatments that you described help? Usually
not. Not in terms of DBS. We see a lot of folks who get tremor after a stroke. The tremor from stroke can be due to a lot of things. If it's from weakness in the limb, the only thing that's going to help that is physical therapy to strengthen it. If the weakness is, if the tremor is coming from spasticity or tightness, we can do Botox injections to loosen it up to free the tremor. Usually tremor from stroke isn't from the brain itself, though. Usually it's something that it's the limb that's reacting to the changes from stroke. So again, treatable, but we have to really identify where it's coming from to have the appropriate treatment.
Great. Rory asks, is there an age limit for DBS? But I'm assuming that the question is related to somebody having brain surgery. What are the limitations there?
Yes, and that it's all about your candidacy for surgery. So I've seen very young 85-year-olds, I've seen very old 55-year-olds, right? So it's all about, are you a good candidate for surgery? Now, that being said, once you get over the age of 80, your potential response to DBS goes down because in your 80s, the structures of the brain are shrinking as a normal part of aging. So the areas that we're stimulating tend to be smaller and harder to get to respond. So the ideal would be before 80, I'd say.
Okay. And then is the lead left in, Anne says, is the lead left in the brain after the brain stimulation, or how long is the lead left in the brain?
It's all part of you. So the lead
Okay.
runs, it is delivering therapy all the time. It's actually putting the energy into the pathway to make it stop. So the leads are in, the device, the pacemaker-like device is in forever. And we interact with it through an iPod, essentially, that connects to it via Bluetooth to change how it's delivering therapy at the source. It's really cool stuff.
Okay. So now, big surprise. We have 13 more questions that were over in the Q&A queue. So I'll run through these for you. Okay, let's see. Joe said, do essential tremors come and go, or do they get better or worse without treatment?
Yeah, they can fluctuate. Everything in life fluctuates to a certain degree, depending on the day, the stimuli, the stressors in your life. Yeah, it can fluctuate. That's all part of it. But it's about trying to find the trend overall and try and treat it.
Let's see. Our tremors, okay. Some of these are duplicates. Carolyn says, I don't consider my tremor very essential, but it's a huge annoyance.
Agreed. Yep. Yeah, I'd like to do away with it for you.
Let's see. Okay. Okay. I think we're actually clear. Can we talk about, okay. Can you talk about the types of tremor that, especially voice tremors?
Yes.
Yeah, you haven't talked about that.
Yeah, voice tremors can be part of essential tremor. You can get a vocal tremor that goes along with the arm tremors and the hand tremors. You don't have to. It's actually not the norm to get voice tremor, but you can. But you can also get vocal tremors from other things. There's something called spasmodic dysphonia, which is an actual type of dystonia of the voice. Like, what was the lady from NPR? Reem, I think her name was, for a long time.
Diane Reem, yeah.
Diane Reem. She had the vocal tremor that kind of talks like this, right? That's actually a problem of the vocal cords themselves. So if you have a lot of voice tremor, we still try the medicines we got, but usually we bring in an ear, nose, and throat doctor too, because there are things they can do to the vocal cords to try to help. Yep, Diane Reem, she's the one.
Let's see. Is there any, this sort of came up before, but just reiterating, is there any correlation between essential tremor and Parkinson's and Alzheimer's?
Usually not. For the vast majority of people, no. Essential tremor is its own thing. You don't have to worry about those other things.
Wow, you've got a fan club here. Constipation, chronic long-term constipation. When you spoke several months ago, you talked about how this seemed to be a condition of Parkinson's disease, and you gave a recipe to keep in a refrigerated drink. And could you talk about that again? Sure.
Now, I always wanted to be famous for something, as every little kid did. I do not want to be famous for a constipation recipe, but I'll take it. Sonia, do you have it? Can you pop it up into the chat for folks too? Because what it is it's a good natural way. It works for anybody with any kind of constipation. You get a mason jar or something you can put in the fridge, and you put in it a cup of bran cereal, a cup of applesauce. Apple cinnamon tends to taste a little better, and a cup of prune juice. You mix it all up and you put it in the fridge, and every morning you eat 2 big old tablespoons of that, and it should make you right as rain. It tastes a lot better when it's cold. It kind of looks like a cold cereal. It tastes pretty good.
Great. And Carolyn asks, are there any natural or homeopathic supplements that could help someone with the essential tremor?
Not usually. The best natural supplement for essential tremor is actually marijuana, funny enough. So we have been treating essential tremor and Parkinson's to a degree with hemp and with marijuana since the 1700s. Now that it's becoming more allowed in terms of medicinal use, we're seeing an uptick in the use of that, especially in Maryland and DC, where it's easier to acquire. It works. It does help, and it helps with the anxiety and stress component that goes into it too. Outside of that, there's not really a supplement I can point you to. Some people say a little magnesium can help, but at the end of the day, it's really about getting a lot of exercise in your life, helping with stress, and finding a good combo of medicines to help it.
And Donna asks, what dosage of propanol will typically be effective? And I'm assuming that you first try to treat somebody with medication, or do you ever sort of just say, no, DBS is the way to go?
Tend to always start with medicine. If we can make it better with a pill, that's much better than putting a device in your body. In Propanol, the effective dose is very person dependent. The starting dose of once daily is 60 milligrams. It goes up 60, 80, 120, 160 on up. I've got patients that take 250 or 300 milligrams a day, and that's the dose they needed to get better. So it's about communicating, about seeing how something works, and then adapting.
And on that recipe that Sonia just shared, how often do you take that?
Every morning, 2 tablespoons.
Okay.
You can take 3. Take 3 if you like it. Eat half the jar. It'll blow you out.
Yep. And then let's see. Sandy asks, I'm assuming that she's referring to an essential tremor. She asks, can it affect the grip strength? I'm assuming that when your tremor is treated, that you'll have better grip strength.
Yes, because you're not shaking. So just like I think it was your mom, you said, you get more energy because it's tiring to shake all the time. It's tiring to try to adapt to this. So treating it tends to help with energy, and it tends to help with the ability to use your hands. It's not really because the strength is less. It's just a lot easier to use your arms and your hands when they're not shaking.
Let's see. Claire says, I guess she had asked a previous question that we had addressed, and she said, to clarify, my tremor is an action tremor. Some call it a writing tremor. I don't have it at rest. I only have it when I use my hand for writing, eating, drinking, or putting on eye makeup. Oh boy, I bet you that's a really difficult task for people to do.
That sounds like an essential tremor. That doesn't sound very dystonic to me, but it would take a good exam to help differentiate between the two. Dystonic tremor, we used to call writer's cramp. So it was the people who would be writing and their hand would cramp up. A dystonic tremor tends to be very specific to a specific task. So people with dystonic tremor who have writer's cramp, it happens when they're writing, but they can do their makeup, they can eat, they can do everything else fine. It's that one task that tends to bring it out.
Okay.
Essential tremor affects all the tasks.
Martha asks, with DBS, what should you not do, such as going through airport screening and things like that?
Yeah, you can go through airport screening. I just tell folks to check it when they're on the other side to make sure that it didn't turn off because of all the different things they're bombarding you with. But it's fine. You can stand in front of a microwave. You can do anything. The things with DBS we don't want people to do are things that move the head around a whole lot. Like we don't want you riding roller coasters because these leads are in the brain. And if you're jostling side to side, it ain't good for you. And probably you shouldn't be skydiving because of the head movements, that kind of thing.
Okay. And okay, I think, is there a genetic test that can be taken for this trait?
Yeah, there's not. If only there were, there isn't.
All right. And then for Diane, she asked this question early on when I think you were talking about the issue of dopamine being produced. And she asks, why is that?
So the dopamine reduction in Parkinson's, remember, dopamine being low is not an essential tremor thing. It's the hallmark dysfunction at the source of Parkinson's disease. So it happens, we think, this is the commonly held belief right now, is that Parkinson's actually comes from a combination of a predisposition for it, then interacting with some environmental factor that tends to make it symptomatic around age 65. And that producer of dopamine in the brain just starts making less. And as the level gets lower, symptoms become pronounced because the body can't compensate.
Great. I can't believe it. We got through everything. Let me just double check to make sure. Joan has her hand raised. A lot of times that is by accident, but Joan Rubin Kritz, if you did have a question you wanted to ask, you can unmute yourself there and ask it. If not, don't worry. And Dr. Falconer, once again, this has been well attended and tons of interactivity, which is what we love on these discussions. Any sort of closing thoughts or statements that you'd like to share with the audience?
Yeah, I think all of that is wonderful, right? They're all treatments. They're all things we can do to make people better. But remember what I said at the beginning. There's a huge gap between the amount of people with essential tremor and the small percentage who try these treatments. It's our job to go out there and talk to our friends, our family, our cousins, our neighbors, our Elks Club members, our church members who are shaking, and in a very respectful and polite way say, you know, I saw this doc and he said that you don't have to live with tremor. And that just starts that thought process and the investigation and the education that goes along with it, that, hey, maybe I don't have to live with this anymore. And that's where it leads people to see people like me, just like your mom. We then treat them. Then for the first time in 30 years, she has no tremor, has more energy, and feels great. And the best part is she never thought it would happen, which makes it that when we do make it happen, it makes it all the sweeter.
Yeah, and I will say, as somebody who had that conversation twice, it is well worth it. And we're taping this conversation. So the best thing about this discussion is, you know, the stats because you're living it. People don't know about this. So we're taping this conversation and I will send this to you. This is a great thing that you can share with your loved ones and just say, hey, take a look at this discussion here. And that's how I did it with my mom and my cousin, and had some amazing life-changing results. Oh, Edward asks, where is your clinic located?
Hey, so we're virtual still. So we're doing virtual clinics still, which is a nice way to access us. And then we have clinics in person in Alexandria, Fairfax, Fair Oaks, and Gainesville, Virginia. Go ahead and hit up our website. You can go to Inova, INOVA.org/move. I'll put that in the chat, /move. That is our website where you can find out about all of our specialists, all of our treatments, and our locations.
Great. And as you'd said before, like somebody in Maryland can consult with your practice.
Absolutely.
So Jake or Jackie has a question. Any correlation with shaking leg syndrome?
So shaking leg syndrome, some people would argue is just a description of symptoms, not a cause. Most people with shaking leg syndrome have a problem that we need to identify. There really isn't a true shaking leg syndrome. That's just the symptom. And we need to figure out why the legs are shaking, which can be due to many things, to come up with the best way to treat it.
Okay, great. All right. Well, we got through them all. And let's see, Susan Rannick says, kudos to Dr. Falconer and your efforts to educate and empower others and make informed choices. Thanks for that, Susan. And I couldn't agree more. And we'll look forward to having you back on again. The door is always open for you and your team. And thanks so much for everybody for making such a lively, interactive discussion today.
Thank you, everybody. Bye.
Bye.